Friends, today we will be discussing about the pathology of breast cancer. Breast cancer can broadly be classified into two groups, that is a non-invasive cancer and an invasive cancer. Now, what is a non-invasive cancer and an invasive cancer? To understand this, let us first see the basic definition of cancer. Cancer is simply defined as uncontrolled division of cells. When a cell develops neoplastic or cancerous features, it starts dividing in an uncontrolled fashion. Now, when these rapidly dividing cancerous cells remain confined by the basement membrane, that is, when these cancerous cells do not invade the basement membrane or the surrounding structure, then it is called as a non-invasive cancer. On the other hand, when these rapidly dividing cancerous cells invade the basement membrane or the surrounding structure, then it is called an invasive cancer. Now, a non-invasive cancer, which is also called as carcinoma in situ, can be divided into ductal carcinoma in situ and lobular carcinoma in situ, while an invasive cancer is divided into invasive ductal carcinoma and invasive lobular carcinoma. Here we see there are two terms, one is the ductal carcinoma and another is the lobular carcinoma. Now, what is a ductal carcinoma and what is a lobular carcinoma? Ductal carcinoma is the cancer which arises from the duct, while lobular carcinoma is the cancer which arises from the terminal duct lobular unit. With this much background of information, we can say that the breast cancer can be divided into non-invasive and invasive cancer. A non-invasive cancer includes ductal carcinoma in situ and lobular carcinoma in situ, while an invasive cancer is divided into ductal carcinoma and invasive lobular carcinoma. An invasive ductal carcinoma includes invasive ductal carcinoma NOS, not otherwise specified. It is also called as non-special type of cancer. And the other group of cancer which is called as the special type of cancer, and it includes medullary carcinoma, mucinous carcinoma, tubular carcinoma and papillary carcinoma. These carcinomas can be remembered with the mnemonic MTP, which includes medullary and mucinous carcinoma, tubular carcinoma and papillary carcinoma. Now coming to DCIS. What is DCIS? DCIS is ductal carcinoma in situ or a non-invasive carcinoma which arises from the duct. Suppose this is a normal duct and this is the normal lining epithelium of the duct. Now when this lining epithelial cell becomes malignant, what happens? These malignant cells within the duct start proliferating and make papillary growth or papilla-like growth inside the ductal lumen. And in this stage, it is called as papillary form of ductal carcinoma in situ. The continued proliferation of these cancerous cells fill almost whole of the duct, and only small rounded spaces are left behind in between the cancerous cells. It gives this whole picture like that of a cribriform. So the cribriform appearance of ductal carcinoma in situ takes place, and that's why it is called as the cribriform type of ductal carcinoma in situ. The continued proliferation of these cancerous cells fill the whole duct. Now no vacant space or free spaces are left behind, and the whole duct appears to be completely packed with cancer cells. And it gives this duct a solid appearance. That's why it is called as solid type ductal carcinoma in situ. The continued proliferation of cancerous cells further distend the duct, as a result of which cells which are in the center of the duct, the vascularity of those cells get jeopardized, as a result of which necrosis takes place. And the necrosis is the hallmark of ductal carcinoma in situ Komedo type. At the site of necrosis, calcification also takes place. Now, if these cancer cells keep on proliferating, what will happen? These proliferating cancer cells after some time will come out of the ductal system and invade the surrounding structure. And if this happens, it is called as invasive ductal carcinoma. Now, Whole story can be summarized in this diagram. See, suppose this is a normal duct and this is the normal lining epithelium of the duct. If these lining epithelial cells become malignant, then initially there occurs papilla-like growth inside the ductal lumen, which is called as papillary type of ductal carcinoma in situ. Further proliferation of these cells fill almost whole of the duct. Only small areas of rounded spaces are left behind, giving it a cribriform like appearance. This is called a cribriform type of ductal carcinoma in situ. Continued proliferation of these cancerous cells fill the whole duct, and the whole duct is completely filled by cancerous cells or become packed with the cancerous cells, and it gives the appearance of a solid type. That's why it is called as the solid type of ductal carcinoma in situ. Continued proliferation of these cancerous cells distend the duct, and the vascularity in the central part of the duct gets jeopardized, as a result of which necrosis takes place. And this necrosis is the hallmark of comedo type of ductal carcinoma in situ. Continued proliferation will cause the cancerous cells to come out of the duct and invade the surrounding structure, and it will lead to development of invasive ductal carcinoma. Now, ductal carcinoma in situ is usually seen in women, but it can also occur in male. DCIS or ductal carcinoma in situ leads to invasive ductal carcinoma. Majority of the cases are diagnosed on mammography, and the typical diagnostic feature on mammography is microcalcification. DCIS can be divided into non-comedo type and comedo type. Presence of necrosis is the hallmark of comedo type of ductal carcinoma in situ. Non-comedo type includes papillary carcinoma, cribriform DCIS, and solid type of DCIS. DCIS is also classified as low grade, intermediate grade, and high grade, that is grade 1, 2, and 3, depending upon the nuclear characteristics. VNPI, the Von Neuss Prognostic Index. It is an attempt to determine the aggressiveness of ductal carcinoma in situ. It predicts about the probability of risk of local recurrence after breast conservation surgery or therapy. The characteristics which are included in VNPI includes the size, margin, and pathological classification, that is the nuclear grade of the ductal carcinoma in situ, and it is scored between 3 to 9. Higher the score, poor the prognosis. Now coming to lobular carcinoma in situ. The lobular carcinoma in situ arises from terminal duct lobular unit, and it is characterized by presence of intracellular mucoid globules. It is seen exclusively in women and not seen in men. Why? Because the lobules are absent in men. That's why lobular carcinoma in situ is not seen in men and seen only in women. Lobular carcinoma in situ occurs at a younger age compared to DCIS, and there is a slightly increased incidence in white women. There is higher incidence of multicentricity, multifocality, and bilaterality in lobular carcinoma in situ. Subsequent invasive cancer which takes place in lobular carcinoma in situ can take place in either breast, and the subsequent invasive cancer can either be a lobular carcinoma or an invasive ductal carcinoma. So lobular carcinoma in situ is not an anatomical precursor of invasive lobular carcinoma, rather it is a marker of increased risk of invasiveness. Now the whole discussion can be summarized in this chart. Breast cancer broadly divided into a non-invasive cancer and an invasive cancer. A non-invasive cancer further subdivided into ductal carcinoma in situ and lobular carcinoma in situ, and an invasive cancer further subdivided into invasive ductal carcinoma and invasive lobular carcinoma. Invasive ductal carcinoma subdivided into non-spatial type of cancer and spatial type of cancer, which includes MTP, that is medullary, mucinous, tubular, and papillary type of carcinoma. Ductal carcinoma in situ DCIS arises from the duct, seen mainly in women but can take place in men also. Pathologically, it is divided into papillary, cribriform, solid, and comedo type. Also classified into low, intermediate and high grade, typically diagnosed by mammography, and the characteristic feature is the microcalcification. It leads to invasive ductal carcinoma. It's an anatomical precursor, and VNPI is used to determine the aggressiveness of the DCIS. LCIS, lobular carcinoma in situ, arises from terminal duct lobular unit, seen only in women, not seen in men. Slightly increased incidence in white women, occurs at a younger age compared to DCIS, characterized by presence of intracellular mucoid globule. There is no characteristic feature on mammo, that's why it is difficult to diagnose. Higher incidence of multicentricity, multifocality and bilaterality. Subsequent invasive cancer can occur in either breast, and it may be either an invasive ductal carcinoma or an invasive lobular carcinoma. That's why it is not an anatomical precursor of invasive lobular carcinoma, rather a marker of increased risk of invasiveness. Thank you.